Hello everyone, a very good morning to all of you. I guess I'm live. Give me a minute to confirm. If I'm live, I will start the session ahead. Give me a minute. Yes. Yes. So I think it's working. Give me a thumbs up in the chat box if I'm clearly visible, audible. Yes. So I guess the video, audio, everything is good. Yes. So very good morning to all of you. I am Dr. Priyanka Sachdev here, and today I'm here to teach you a very important topic, that is thyroid tumors. So today we are going to study thyroid tumors, that is endocrine pathology. Now this topic is extremely important for university exam students. Every year, almost every year, questions come from this topic. Either you will get a long question on this topic, right? So you have to write all the thyroid tumors, describe the gross and microscopy and everything about it. And you can get short question on each individual tumor, the papillary carcinoma, follicular carcinoma, medullary carcinoma likewise. But it is damn sure that in your university exam, you are going to get question from the thyroid tumors. There is much more probability. And this topic is ultra important for the competitive exam. Many MCQs come from this topic, the 4 type of thyroid tumors. So without wasting any further time, let me go ahead, right? So let me start with the thyroid tumor. Before starting thyroid tumor, in the first 2 minutes, let me give you an overview about the thyroid. So thyroid is the largest endocrine gland. We all know that. Can you see? In thyroid gland, we are having 2 lobes, the right lobe, the left lobe, and connecting the 2 lobes is the isthmus. This is isthmus. So there is right lobe, left lobe, and the connecting between the 2 is the isthmus. And thyroid gland is the largest endocrine gland in human bodies with 2 lobes and isthmus. The weight of the thyroid in adults is 15 to 25 grams, and measurement is 5 into 3 into 2 centimeter approx. Approx it's 5 into 3 into 2, right? Now it secretes 2 hormones, the thyroid hormones. Basically, there are 2 type of thyroid hormones, T3 and T4. T3 and T4. The number 3 and 4 indicates the number of iodine present in its structure. So T3 is triiodothyronine. There are 3 iodine, right? And T4 is thyroxine. It is having 4 iodine. Both are derivatives of thyronin. The thyronin, which is formed from the tyrosine amino acid. Anyways, it's the structure. Let me tell you the cells present in this gland. In this gland, 2 types of cells are present, the follicular cells and parafollicular cells. Listen here, see. Can you see? This is the structure of thyroid gland, the normal thyroid gland. If you can understand what is normal, it's easy for you to understand the pathology, the diseases, the tumors. Right? In normal thyroid gland, we are having circular structures. These circular structures are known as follicles. What it is known as? It is known as follicles. The circular structures are known as follicles. The cells lining the follicles, can you see these cells I'm marking right now? The cells lining the follicles, the circular structures are known as follicular cells, right? And between the follicles, can you see these cells? This cell, this cell, this cell. The haphazard cells present between the adjacent follicles are parafollicular cells or C cells. So basically 2 types of cells are there. What are the 2 types of cells? In the structure of the thyroid, we are having circular structures known as follicles. The cells lining the follicles are follicular cells, right? These all are follicular cells I'm drawing right now. These all are follicular cells, right? They are follicular cells. And the cells between the follicles are parafollicular cells or C cells. Now today I am going to teach you 4 types of thyroid tumors, the malignant tumors of the thyroid. I will teach you papillary carcinoma, I will teach you follicular carcinoma, I will teach you medullary carcinoma, and the last is anaplastic carcinoma. All these 4 carcinoma, among these 4, only medullary carcinoma arises from parafollicular cells. The remaining 3, that is papillary, follicular and anaplastic, they arise from the follicular cells. You got my point? So you should know the cell of origin in all the tumors. Give me a thumbs up. Osama, Bundela, give me a thumbs up. You got it? Say yes, right? So you should know the cell of origin. I will tell you in detail also, but see, this is the structure of the thyroid. Now tell me the hormones which are secreted by these cells. I'm telling you 2 types of cells, the follicular and the parafollicular. So basically the follicular cells secrete T3 and T4 and parafollicular cells secrete calcitonin. I'm telling you the 3 tumors, that is papillary, follicular and anaplastic, they arise from follicular cells, right? So patient have more T3 and T4 in the blood when they have these tumors. But the medullary carcinoma arises from parafollicular cell. So when a patient comes with medullary carcinoma of thyroid, the patient have more calcitonin in the blood. You got my point? More calcitonin causes hypocalcemia, right? So I will tell you all this in detail, but you must know the basics. If you know the basics, it will be easy for you to understand. When I will teach you that in medullary carcinoma of thyroid, patients presents with hypocalcemia, you should be able to understand it. Why? Because medullary carcinoma arises from parafollicular cells. Parafollicular cells secrete calcitonin, and calcitonin lowers the calcium. That is the reason. So there is connection, everything. Everything is connected with each other. You should know the basics. Anyways, let me start the tumors. Without wasting any further time, let me start the 4 type of malignant tumors of thyroid. What are the 4 malignant tumors of thyroid? Can you tell me the names? So I have told you the 4 names: papillary carcinoma, follicular carcinoma, medullary carcinoma, and anaplastic carcinoma. Now ultimately this is the master table, but this table I will read completely at the end of the session. First we will study each of them in detail: the gross, the microscopy, the risk factor, the mutation, the age, the gender preference, everything we will study in detail. At the end, this table will be completed and I will read this table in front of you in a comparative manner, and it will be fun for you, right? Let me start with the first tumor. In this sequence only I am going to teach you the 4 tumors. I will teach you first papillary carcinoma, then follicular carcinoma, then medullary carcinoma, then anaplastic carcinoma. Let me start the first tumor, papillary carcinoma. Are you people with me? Give me a thumbs up in the chat box, everyone who is watching me live, all the students. Can we start? Can we start? Advice for all of you, you yourself can make this table right now. Take out your notebooks, take out your pen, take a page. Divide the page into 4 columns. For the 4 type of tumors I am going to teach you right now. The 4 type of thyroid tumors: papillary, follicular, anaplastic, medullary and anaplastic. In this PFMA, in this sequence I am going to teach you. Initially you have to study in what sequence? I will teach you the introduction, the most common age in which they are present, the gender preference, so female versus male, whatever, the gender preference. After that, the mutation, exact mutation, the etiology, the risk factor, then gross finding. The most important is the microscopy. Draw the microscopy of the 4. Many MCQs come from the microscopy. And in the end, prognosis. I am leaving only one topic here, the treatment part. The treatment is dealt in surgery, right? So various tumors treatment is dealt in surgery, right? So whether it is near total thyroidectomy, complete thyroidectomy, total thyroidectomy, partial thyroidectomy, various types of surgeries are there. So the treatment part will be dealt in surgery, except treatment part, I will give you a comparative analysis here. So I advise all my dear students to make this table of your own. I will provide you notes also. This table is there with me. But if you make your own table, now, if you draw it right now along with the lecture, it will fit in your permanent memory, right? So let me start with the first one without wasting time. Papillary carcinoma of thyroid. Among the 4, it is the most common one. Can you see here? See the percentage wise. Papillary carcinoma, out of the total, it is 75 to 80% is this one only. So it is the most common one. 75 to 80% of the thyroid tumor is papillary, right? The second most common is the follicular, right? It's 10 to 20%. The third most common is the medullary. It's 5%. And rare of the rarest is anaplastic. It's less than 5%. So in this sequence only I am going to teach you. Papillary, the most common, anaplastic, the least common. So you should know the frequency, right? And it is the thyroid carcinoma which is arising after radiation. So the most important risk factor is radiation in the neck. If some person have radiation in the neck, there are chances in future the person can have papillary carcinoma of thyroid. So that is a risk factor you can see. And thyroglossal cyst. There are 2 risk factors, right? What are the 2 risk factors you must study here? The 2 type of risk factors, it's not written here. So the 2 type of risk factors is the radiation and thyroglossal cyst. Learn the risk factor of all 4. All 4 the risk factors are different. Come on the gross. In the gross, this is the gross. Can you see the gross? Can you all see the gross? Now this is the thyroid gland. Let me tell you, this is a thyroid gland. In the thyroid gland, this is the tumor. This one. The circular structure is the papillary carcinoma. Now what do you mean by the term papillary? Papillary का मतलब क्या होता है? What do you mean by the term papillary? Papillary means papilla. Papilla means finger-like projection. Can you see the fingers? The finger-like projections are known as papilla. So papillary carcinoma is known as papillary because we can see the finger-like projection in gross as well as microscopy. Can you see finger-like projections here? Can you see this is a projection, this is a projection, this is a projection. I can see multiple finger-like projections in this diagram. So basically, grossly, the hallmark is papillae projection. That is finger-like projections, right? And the tumor is grayish white, hard like a scar. So I can see a tumor which is gray white. It is like a hard tumor. And the most important thing which you have to learn is the papillae. You have to learn its papillae. Give me a thumbs up, everyone. Give me a thumbs up if you got the meaning of the papillae. What do you mean by papillae? Papillae का मतलब होता है finger like projections. Finger. Can you see my fingers here? Can you see my fingers? So the projections are like finger. It's like this. So it's finger like projection, right? So grossly also, microscopically also. So grossly you have to take only one word in consideration. Finger like projections. That's it, right? Coming on microscopically. ठीक है, microscopically 4 points, one by one. Don't learn microscopy. Try to draw it. Microscopy has to be drawn. So draw the microscopy, right? This is the diagram. Can you see the diagram? What you can see in the diagram? Can you help me in description? You can see where are the tumor cells. Where are the tumor cells? Okay. These all cells are tumor cells. One by one I am drawing. Can you see it? Can you see it? So the tumor cells, now there is a peculiar way in microscopy how to describe it. The first thing you have to say the pattern. First say the pattern. How the tumor cells are arranged. Are they arranged in sheet pattern? Are they arranged in papillary pattern? Are they arranged, what is the pattern? In circular follicular pattern? Yes, Osama, it's finger-like. So say the term papillary. So the pattern of tumor cell arrangement is papillary here. The second point, you have to describe the individual tumor cell. Now I will zoom this diagram in the next point and I will show you each and every cell. Describe the cell, tumor cell. First tell me the pattern of their arrangement, then tell me each and every cell. Describe each and every cell, how they look, what is the nucleus, what is the cytoplasm, the nuclear membrane, cell membrane, the size of the cell. Describe everything about the cell as much as you can. And the third thing, any characteristic feature of that particular tumor, you have to describe that. Now this is a particular way, in this sequence only you have to say your description. You got my point? So say the pattern. What is the pattern here? The pattern is the papillary pattern. You all can see papillary pattern. Now in the papillary pattern, let me draw it on a page. So I would like to draw the papillary carcinoma for you, right? So I have to draw the tumor cells. Where should I draw? I should draw on a particular pattern. The pattern is the finger-like projections. I should draw the cells on this pattern. The finger-like projections. You got my point? Let me draw the cells. Few cells. These are few cells which are present in this pattern. The tumor cells, the red color cells are the tumor cells. So they are present in papillae. You got my point. Why I have drawn this diagram? What is forming the core of the papilla? What is forming the core of the papilla? The core of the papilla have blood vessels. The core of the papilla have blood vessels and fibrous strands. It is known as fibrovascular because blood vessels are present. Fibrovascular core. So the papilla core, now see the same thing in this diagram. Can you appreciate? If you can appreciate, give me a thumbs up. Can you see the blood vessels? Osama, Talim, Gajanan, can you see the blood vessels in the core everywhere? In the core of the papilla, I am marking the blood vessels. And near the blood vessels, can you see a pink colored strands, the fibrosis? So the entire core is known as fibrovascular core. So the core is fibrovascular core. It is a hallmark. So fibrovascular stalk pay, the tumor cells are present in a papillary pattern forming a single layer. It is not double layer. Always it is a single layer of the tumor cell. This is the peculiar arrangement. If you got the arrangement, let's describe each cell. Just zoom out and describe any one cell, any one tumor cell. Don't tell me arrangement now. Tell me the tumor cell. So let me zoom this diagram now. I will zoom out this diagram. This is the zoom version, right? Here in the zoom version, I can see individual tumor cells bigger, right? Bigger tumor cells I can see. Now try to describe it. Right? Now see the nucleus. I will show you in the diagram also. The nucleus of each of these cells is like a glass. You know, कांच के जैसी है. कांच के जैसी transparent सी nucleus. It is not opaque. It is like a glass. Window glass, ground glass appearance. It is optically clear nucleus. You know, the glass is optically clear. So the nucleus is clear. It is known as Orphan Annie Eye nuclei. This is typical term given to that. Orphan Annie Eye nuclei, right? I forgot to put the diagram of Orphan Annie. Orphan Annie is a child, right? Uski eyes jo hai na, it looks like a ground glass. This term is given to that. It is a very important MCQ, right? So nucleus ko humne 3 term diye. I will show you. Can you see here the nucleus? If you can concentrate, I cannot zoom it out. I don't have the, zooming out this property here. But if you see any of the nucleus, see the nucleus. Let me show you the complete cell. See, this is the complete cell. I'm not asking you to see the complete cell with pink cytoplasm around. I'm asking you to see the nucleus. The nucleus is optically clear. It is not opaque from inside. So 3 terms are given to the nucleus. Can you see here? This is a more beautiful diagram, I guess. So I can see this is complete cell and I am interested in seeing the nucleus of all the cells. The nucleus is optically clear, ground glass, orphan eye nuclei. Give me a thumbs up. Everyone give me a thumbs up here also. Give me a thumbs up. One more important point inside the nucleus. Ye to ek cheez hui, right? Dusri cheez, in the nucleus you will find 2 more things. Number 1, inclusion bodies. Inclusion, intranuclear inclusion bodies. I will show you. And number 2, grooves in the nucleus. Okay. Have you seen a coffee bean? Not a powdered coffee. Do you drink coffee? Whatever coffee we purchase from the market, it is powdered version. But it is grinded from a bean, which is known as coffee bean. So if you have seen a coffee bean, there is a groove in that, this groove. So the same groove is seen here in the nucleus. Can you see? Okay. I will help you in that. Okay. If you can see this nucleus, if you zoom out, you can see there is a groove here. If you see this nucleus, there is a groove here. See this nucleus, there is a groove here. See this nucleus, there are many nucleus here showing the groove. Give me a thumbs up. Everyone give me a thumbs up. So these are the grooves, right? Apart from grooves, can you see this in this nucleus? See, concentrate here. It's all about diagrams, huh? In this nucleus, can you see this circular thing? A circle inside the nucleus. This circle is the inclusion body. So inside the nucleus, inclusion bodies and grooves both are very common. So what I have learned? I have learned that tumor cell ka nucleus. Currently, I am teaching you papillary carcinoma. I'm going to teach you 4 points about it. 1, 2, 3, 4, the microscopy, right? The first point, I told you the pattern of the tumor. What is the pattern of the tumor? The pattern of the tumor is very peculiar. It's papillary. It's on the finger-like projection. The tumor cells are arranged in papillary pattern with fibrovascular core. Don't forget to say this word. Fibrovascular core in the center. This is peculiar pattern. Learn the pattern. Number 2, describe tumor cell. Describe each tumor cell. What is the peculiarity in that which is not present in other tumors? So the nucleus is classical. What is the classical about the nucleus? In the nucleus, you have to learn 3 things. 1, 2, 3. The first thing, the color of the nucleus is ground glass. Either say ground glass, number 1, or say optically clear. One and the same thing, optically clear. Or say orphan eye nuclei. Orphan Annie eye nuclei. One and the same thing. That is the color. दूसरा उसके अंदर प्रेजेंट है ग्रूव्स. तीसरा उसके अंदर प्रेजेंट है इंक्लूजन बॉडी. So 1, 2, 3, the hallmark of the nucleus. Everyone give me a thumbs up. Come on. Kumar, Adil, everyone. Osama, Gajanan, Talim, give me a thumbs up. Others, everyone who is watching me live. You got it? Say yes. Yes. So that is the tumor cell. We got the tumor cell. After the tumor cell, here also can you see the grooves? How many grooves? Beautiful grooves I am showing you. Concentrate on any nucleus. Inside the nucleus, see the vertical, horizontal line. That is a groove, the horizontal line. The third feature is Psammoma body. What do you mean by Psammoma? P is silent. Huh? In Psammoma, this P is silent. Pronounce it as Psammoma. Don't say P Psammoma. Right? P is silent. So Psammoma bodies क्या होती हैं? These are calcium deposit. This tumor have calcium deposits in that. The calcium is deposited in the form of a concentric rings. The calcium is deposited in the form of concentric spherules or rings. It is known as Psammoma body. In this diagram, I can see one Psammoma body here. Can you see? If you can zoom out, you can see a blue color dot. That is calcium deposition. This is known as Psammoma body. Out of the 4 thyroid tumors, only this have calcium deposition. None of the other will have calcium deposition. If you see, Kumar, absolutely right. Psammoma body is an example of dystrophic calcification, right? So that is the third point, Psammoma body. And the fourth point, the tumor cells show the invasion inside the capsule of the thyroid and the blood vessels of the thyroid. Here it is not shown, but you know the thyroid gland, the 2 lobes of the thyroid gland with the isthmus. Just suppose tumor is present here. So these are the tumor cells, right? They have a tendency to grow and involve the capsule and invade the capsule and go out. So capsular invasion is very common here. Capsular invasion is very common here. Everyone give me a thumbs up. This is the fourth point. So can any one of you help me in the microscopy of papillary carcinoma of thyroid? The 4 points. Can any one of you help me? Please learn the 4 points. First tell me the pattern. Then describe the tumor cell, individual tumor cell, I must say tumor nucleus. Tell me 3 points about the nucleus. Then tell me 2 more hallmark points. Who will tell me? Who will tell me? Yes, help me in that. What is the pattern? The pattern. What is the pattern? The pattern is typical papillary. Papillary pattern. Very good, Gajanan. He is absolutely right. With fibrovascular core is very important. Yes, very good. Can you describe nucleus? Yes, Osama, absolutely right. Absolutely. So say 3 terms for the nucleus. One and the same thing. Either you say ground glass appearance or you say optically clear. Optically clear, right? Or you say Orphan Annie Eye nuclei, right? What is the third thing? The third thing is the Psammoma bodies. Psammoma bodies. And the fourth thing is the capsular invasion. So if you know these 4 things, all the MCQs can be cracked. Along with this 4, draw the diagram, you will get full marks, 5 out of 5 in your exam, university exam, if you are a second prof student. So that's all about the papillary carcinoma. The prognosis is very good. The 10-year survival is up to 90-95% if properly treated. If you do the proper treatment, it's very good. Almost 90-95% people survive up to 10 years. More than that, of course. Prognosis is good. We are done with papillary carcinoma, the first carcinoma. We are done with that. Everyone give me a thumbs up. We will read this column and go to the next one. So it's the most common, right? It is present in all age. The young people can also have, the old people can also have. But it is more common in female, 3 times more common. The female is to male ratio is 3:1. You have to learn this ratio in all, right? So it's 3:1, right? It is having maximum relationship with the radiation. The risk factor is the radiation and thyroglossal cyst. Gross I told you, microscopy I told you, right? Prognosis is very good. Is very good. That's all about papillary carcinoma. Coming on the second carcinoma, the follicular carcinoma, it is the second most common type. It is 10-20%. Papillary was 70-80% common. It is 10-20%. The frequency, the incidence. So it is the second most common type. Come on the gross. This is the gross appearance. This is the gross appearance of this tumor. Right. So in the gross, nothing very important to learn, but areas of hemorrhage, necrosis and cyst are very common. Can you see here? I can see the areas of hemorrhage, the red areas of hemorrhage. I can see cystic, small cystic cavities are common. So areas of hemorrhage, necrosis and cyst are common. There is no papillae. There is no papillae. And tumor is grayish white and hard. In between, red areas are present. So gross is not very important, to be frank. I'm sorry. Okay. Am I back? I guess some problem was there. I guess I'm back. Give me a thumbs up. I guess I'm back. Yes? Yes. Okay. Here in follicular carcinoma, the pattern is follicular. What do you mean by follicular pattern? It's circular. See the diagram. It's not papillae. Where are the tumor cells? See, I'm drawing the tumor cells. These are the tumor cells. They are arranged in a circular pattern. They are arranged in a circular pattern. You know, the circular pattern which are known as follicles. So the pattern is not papillary. No, it's not papillary. The pattern is the follicular. So say the pattern is follicular of various size. Some follicles are small, some are medium, some are large. So various size are present. The follicles, they lack papilla. They don't have papilla. No papilla, number 1. No ground glass nuclei. No Psammoma bodies. All these things were peculiar of papillary carcinoma. They are absent in follicular carcinoma. You got my point? You got my point? On the contrary, here the nucleus is hyperchromatic. The opposite of ground glass. एक होता है transparent, एक होता है opaque. तो वहां पे nucleus है transparent, like a glass, optically clear. यहाँ पे nucleus है opaque. Opaque मतलब hyperchromatic. You got my point? See the nucleus of any of the cell. You will realize. See the nucleus. The blue are the nucleus. They are opaque. They are not transparent. They are opaque. So here the nucleus are hyperchromatic. So the nucleus differ. The pattern differ. Give me a thumbs up. You got it? Number third thing. वहाँ पे capsular invasion was common. Here vascular invasion is more common. It invades into the blood vessels, into the capsule also, and into the blood vessel. Both things are very common here, very common here. And the next important point here, can you see this is a blood vessel shown? See. Can you see a blood vessel here? Yes, you all can see a blood vessel here, I guess. And if you can notice, the tumor cells are invading inside it. So vascular invasion is very common, right? And can you see this is the, what it is? The pink color fibers. Can anyone tell me what is this? The pink color fibers. It is the capsule of the gland. And can you see the tumor cells are going through the capsule from here to there, from here to there. So capsular invasion and vascular invasion both are shown here. The capsular invasion and vascular invasion are very common. Give me a thumbs up. The next point is sometimes it is having a variant. The variant of follicular carcinoma. It is known as Hurdle cell carcinoma. So basically Hurdle cell carcinoma or oncocytic carcinoma is a variant of follicular carcinoma. You will say, ma'am, what is the difference between the two? Why it is a variant? Here, see the cells. The cells are in follicular pattern only. The pattern is not shown. It is a zoomed diagram. But here, what I can notice, the cells are bigger in size. They have more pink cytoplasm. Pink se mera matlab hai eosinophilic. So cytoplasm is abundant and it is more eosinophilic. So such a tumor in which the arrangement is same, you know. So if you draw, the arrangement is same. The arrangement is like follicular only. The circles are there and tumor cells are present here, like this only. So in follicular, in Hurdle cell, both of them, the arrangement is same, right? But if it is Hurdle cell, now all these cells are bigger, abundant cytoplasm with more eosinophilic. Eosinophilic se mera matlab hai pink cytoplasm. So it is a variant of follicular carcinoma. In simple follicular carcinoma, the cells are small with not very eosinophilic cytoplasm. So that's the cytoplasm, color of the cytoplasm which differentiate Hurdle cell from follicular cell. Give me a thumbs up if you got it. Give me a thumbs up. So basically Hurdle cell, also known as oncocytic carcinoma. It is a variant of follicular carcinoma. You got it? Give me a thumbs up if you got it. So see the diagram. The cells are more pink. Of course, you can notice they are more pink. They are more bigger in size. They have abundant cytoplasm. So these are the differences. It is a variant, right? Having a little bit better prognosis. It is a variant of follicular. Rest all the same as that of follicular. And the prognosis is average, not very good. The prognosis in papillary carcinoma was 90%, the 10-year survival. Here the 10-year survival is 70%. So you can say average, not bad, but average, right? So वहाँ पे 90% था, यहाँ पे 70%. You got my point? You got my point? So can any one of you help me in drawing the two diagrams, the papillary carcinoma and follicular carcinoma? Can any one of you help me? Okay, don't draw it. I'm not interested in drawing. Tell me the pattern in each of them. Describe the tumor cell in each of them and tell me the characteristic hallmark finding in each of them. Who will help me? Anyone among the audience? Yes, Adil, Osama, Kumar, Harnani. Anyone? Yes. So pattern in papillary, you will say, ma'am, papillary only. The pattern in the papillary is papillary with fibrovascular stalk, with fibrovascular core, right? And the pattern here is follicles, follicular. Follicles means circular of various size, small, big, large. Okay? Follicles of various size. Can you describe the tumor cells here? Describe nucleus here, describe nucleus here. So here the nucleus is ground glass, also known as optically clear, right? The same thing. Also known as Orphan Annie nucleus, because the nucleus is transparent basically. Transparent को ये सब terminology बोलना है हमें, catchy terminology. But nucleus is opaque here. Here the nucleus is opaque. It is known as hyperchromatic nucleus. Hyperchromatic nucleus. You got my point? Yes. Absolutely right, Gajanan, Osama, Adil. Very good. Now, can you tell me one characteristic finding? Here, the most important characteristic finding was Psammoma bodies. Psammoma bodies means calcification. Calcification in the form of rings, in the form of the spherules. Here, there is no Psammoma bodies. यहाँ पे Psammoma bodies नहीं है. The characteristic feature here is two invasion. The capsular invasion and vascular invasion. Very prominent, right? I must say capsular and vascular invasion is present here only. Please understand, but not very prominent. I will give 1+ only, but here I will give 3+. So understand the difference. If I say capsular and vascular invasion very prominent, so it's of course follicular carcinoma. I'm saying it is absent in papillary. No, it is also present in papillary, but not very prominent. Give me a thumbs up if you got my point. Everyone gave me a thumbs up, right? So that is done. Now follicular have one variant. Follicular carcinoma have one variant which is known as Hurdle cell carcinoma, also known as oncocytic carcinoma, in which the cells are little bit bigger. They are little bit bigger with abundant cytoplasm and more pink, more eosinophilic cytoplasm. So it is a variant of follicular. Papillary don't have any further variant. There are variants, but at your MBBS level, now you don't have to learn the variants for your exams. That's it. So if you learn that, I can challenge, you can excel in your university exam, you can get full marks, and in your competitive exam, all the MCQs will be done. Give me a thumbs up. You got my point. One thing I forgot in papillary. I don't know whether, yeah, apart from the nucleus, tell me two more features na in the tumor cell. Nucleus में एक तो color of the nucleus, दूसरा nucleus के अंदर दो और चीजें हैं. Nucleus के अंदर grooves are there and nucleus के अंदर inclusion bodies are there. We cannot afford missing that, right? The next point I must mention here, instead of writing the differences, draw it. Once you will draw it na, you will never forget. Just for example, if I am a second prof student and the 5-mark question coming in my exam, draw a well-labeled histopathological microscopic diagram, morphological diagram of papillary carcinoma. So how I will draw? So first of all, I will try to draw the pattern. I will take a box. I will not learn it from book, right? What I have seen the mentality of second prof students now, they try to mug the diagram and copy it as it is. Don't copy. The labeling should be adequate. बाकी तो अपने मन से बनाना है. The features should be there. So I will try to draw 2, 3, 4 papilla in the diagram to show the basically papillary pattern, right? Inside the papilla, I will try to draw the fibrovascular core. I will draw the blood vessels and I will draw the fibrosis. The pink color fibrotic strands I will draw everywhere. So the pattern is there. After that, I will try to draw the cells. Few cells I am drawing, the big cells lining the papilla, the tumor cells. In the tumor cells, I will try to draw the nucleus. Now, in some nucleus, all the nucleus will be optically clear. I will not fill color inside that. I will draw only outline to show it is optically clear. In some of the nucleus, I will draw inclusion body. In some of the nucleus, I will draw grooves. And all the nucleus will be optically clear. And I will do adequate labeling. I will get full marks. Use only pink, purple and lilac color pencils for drawing this. You will get 5 out of 5. I can challenge you. Because, you know, in my college where I work, I get many copies to check, the complete batch. So if some student is drawing what is needed and proper labeling, I give full marks, right? Don't try to copy the diagram. Students don't know how to draw diagrams in systemic pathology, in second prof basically. Yes, so this is how you have to do the proper labeling. In the labeling, you know, you have to mark the pattern, you have to show the fibropapillary pattern, you have to show the nucleus, the optically clear nucleus, you have to show the grooves somewhere, you have to show the inclusion bodies somewhere. One thing I forgot to draw here, Psammoma bodies. Draw at least one Psammoma body. The purple color calcification and label it as Psammoma body. So you are drawing 5 labeling now, you will get 5 marks. The examiner who's checking your copy now, answer key is given to the examiner, right? Who's checking your copy. So in the answer key, it is clearly mentioned the student have done 5 labeling. This, give full marks. If the student has done only 4 labeling, so out of the 5, you will get 4 marks. If you have done 3 labeling, you will get 3 marks. Likewise. So labeling is important. Please understand the marks distribution is according to the labeling. Right? So please understand these tricks. If you are following these tricks now, you will get gold medal in your exam. I can challenge you. Right? Okay. Anyways, let me go ahead. Yes, Gaurav, you are absolutely right. The Hurdle cells are seen in Hashimoto thyroiditis also. So Hurdle cell is actually a type of adaptation, you can say. And here it is a variant. Absolutely right. So I am going ahead to the third carcinoma now. We are done with the first one, papillary. We are done with the second, follicular, right? And now I am moving to the third one. The third one is the medullary carcinoma. The medullary carcinoma differs from other three. By that, it arises from parafollicular cell. Here in the thyroid diagram, you can see 2 types of cells. These cells which are lining the follicles are follicular cells, right? And these cells which are between the follicles are parafollicular cells, right? So the 3 tumors. What 3 tumors? Papillary, follicular, and the last one, anaplastic. All these arises from follicular cell. But this third tumor, that is medullary, only medullary arises from parafollicular. So cell of origin is different. The cell of origin is different. That's why the hormone is also different. Parafollicular cell do not secrete T3, T4. Parafollicular cell form calcitonin. So in medullary carcinoma, patient have more and more calcitonin in the blood. So the first thing you have to write, it arises from parafollicular cell or C cell, right? So this is the most important point. That's why patient have abundant of calcitonin in the blood. What does calcitonin do? Calcitonin decreases calcium. It is a hypocalcemic hormone. It decreases calcium. So patient will come to you with hypocalcemia. If you measure the blood calcium level, what is the normal blood calcium level? It's 9 to 11 milligram per deciliter, right? So patient will have less than 9 milligram per deciliter calcium in the blood. So it will give you a suspicion the patient can have medullary carcinoma. It can be because of calcitonin. And from where the calcitonin is coming? It is from parafollicular cell. So patient can have tumor of parafollicular cell. It is the third most common, only 5%, right? See the percentage. Papillary was 70 to 80%, right? Follicular is 10 to 20%. This is 5%, right? Only thyroid tumor, which is equal in male and female, right? Now see the ratio. See the ratio. The ratio is female is to male, right? In papillary, the ratio is 3:1. That it is 3 times more common in females as compared to male in papillary. In follicular, it's 2.5:1. So in female, it's 2.5 times more common as compared to male, right? In anaplastic, the last one, it's 1.5:1. You got my point? So it is 1.5 more common in female as compared to male. But in medullary, it's 1:1. ये बहुत important MCQ है. Out of the 4 tumors, only medullary is equal in male and female. Please learn it. Learn it. Give me a thumbs up. Everyone give me a thumbs up. Everyone give me a thumbs up. What you are asking, Gaurav? If ma'am, if these cells are not well differentiated, then they will also produce cells. What do you mean by not well differentiated means? You want to ask normally or you want to ask in tumor? In tumor, basically the cells are doing hyperplasia, no? Hyperplasia and hypertrophy. Which cells will be anaplastic, so more cells will be there, so they will secrete more calcitonin. Calcitonin is present in all of us, in me, you, all healthy individual. It is secreted by our parafollicular cells in our thyroid gland, but in small quantity, in adequate quantity, right? So it is decreasing the calcium. It is decreasing. We have other hormones, the parathormone, vitamin D, which is increasing the calcium. So the balance is 9 to 11. But if parafollicular cells are more due to the cancer, the medullary carcinoma, so the balance will become imbalanced and the calcium level decreases, right? Can I go ahead? Can I go ahead? So only one among the 4 tumors is medullary carcinoma, in which male is to female is 1:1. So learn male is to learn female is to male. Female is to male in the 4 types of the tumor. Can you tell me the ratio in papillary, in follicular, in medullary, and in anaplastic? Any one of you? In papillary, the ratio is 3:1. In follicular, it's 2.5:1. You have to learn this ratio. Come on. In anaplastic, it's 1.5:1. So basically, all of them are more common in females. You can see it's 3 times, it's 2.5 times, it's 1.5. But in medullary, it's 1:1. So it is equal in male and female. Yes, yes, Gajanan. Yes, yeah, absolutely right. Absolutely right. So can we move ahead? You have to learn the mutation in all 4. Here, the mutation is RET gene. Learn the name of the mutation. RET gene mutation on chromosome number 10. Right. Let me tell you mutation of others also. I forgot to tell you. ठीक है. यहाँ पे only RET mutation is there. Only RET. Right. In papillary also RET gene mutation is there, but it is not very common. Apart from RET gene, some other mutations are also there, like NTRK. In follicular, it's RAS mutation. Right. In anaplastic, it's P53 mutation. Here, RET mutation is the most commonest. Right. All of them can involve the lymph node, but here lymph node involvement is very, very common, the highest among the 4. The lymph node involvement, it is the highest among the 4. Right. One more peculiarity of medullary carcinoma, it is familial tumor. It runs in family. Have you heard about Mann syndrome? There are 3 types of Mann syndrome. Have you heard about it? Mann 1, Mann 2A, Mann 2B. Mann 1, Mann 2A, Mann 2B. So patient have 3 tumors in each of them. You have to learn the syndromes, right? So man 1 में medullary carcinoma नहीं होता. In man 1 you can see other 3 tumors. You can see papillary adenoma in the brain, you can see parathyroid hyperplasia, and you can see pancreas tumor, but it's not thyroid medullary. But in man 2A and 2B, both of them medullary carcinoma of thyroid occurs along with other tumors. I'm not going in detail, but learn it is associated with man syndrome. In the man, it's associated with man 2A and 2B. So it is having familial occurrence. So that is the introduction. In the introduction. So what we have learned in the introduction of medullary carcinoma of thyroid. What are the important points? Can you enumerate any one of you? So the most important point, it arises from parafollicular cells, not follicular cells. So the patient have abundant of calcitonin in blood, which decreases calcium. So patient have more calcitonin, less calcium in the blood because it arises from parafollicular cell. The most important number one finding. Number 2 finding, it's the only tumor which is equal in male and female. So the ratio is 1:1. We have learned that 1:1. We have learned that. The next, the RET mutation. You cannot forget that RET mutation. And the next important, it is familial association associated with man 2A and 2B. So these are the important introduction points you must learn, right? Grossly, nothing important. Again, it is having areas of hemorrhage, necrosis, the tumor is soft, like there is nothing important to learn. You can skip the gross. Gross was important in papillary, it was having typical papillary projection, but gross is not important in other tumors, right? Histologically, here 2 points are important. Number 1, the arrangement. Tumor cells are arranged in small nest. The pattern is nesting. It is known as nesting. I will show you the diagram. And the nests are separated from each other by fibrovascular septa. See here, this is one nest. This is another nest. This is another nest. This is another nest. This is another nest. So all these are nest, small nest, which are separated from each other by fibrovascular septa. So the arrangement of all tumors is peculiar. Concentrate on the arrangement. The arrangement in papillary was papillae with fibrovascular core. The arrangement in follicular was circular follicles of varying size. The arrangement in medullary is nesting pattern. It is known as nesting, which are separated from each other by fibrovascular septa. Give me a thumbs up. Come on, give me a thumbs up, right? So that is the important thing. The second important thing, tell me about the tumor cells. What is the unique in them? The unique in them, they all are uniform. You see, all the tumor cells are of same size. They are not, some are large, some are small. If you see the other tumors, the papillary I already taught you, follicular I already taught you. The tumor cells are pleomorphic. By the term pleomorphic, they are varying in size. Some are big, some are small. But here the uniformity is the hallmark. All the cells are like same size. Uniformity is hallmark. Nothing more important. And this nucleus is hyperchromatic only. Nothing more important about the tumor cells. Yeah, one more hallmark feature here. Here, what is the hallmark feature? The background. Can you see the background? See the diagram, please. I want you to appreciate. See the background pink filler. Can you see the background? Cell को मत देखो. Cell के background में pink color का material दिख रहा है क्या? दिख रहा है तो हाँ बोलो. Can you see the pink color material in the background? The filler material in the background, the pink color. What is that pink color filler? Can you see this? The background of all cells, the pink color filler. Actually, the pink color filler is amyloid. The background is a stroma. So the stroma is of amyloid. Have you heard the chapter amyloid in pathology? In general pathology, in immunology? Yes, amyloid. Amyloid is an abnormal protein which get deposited only one thyroid tumor. The answer is medullary. और किसी में amyloid का deposition नहीं मिलेगा. That is the hallmark feature. If it is a thyroid tumor, it is showing amyloid. It has to be medullary carcinoma. Right. So one hallmark feature you have to pick. So amyloid is present in the background in the stroma. It is a characteristic feature. Now, can you tell me the stain for the amyloid? Special stain. It's Congo red. Have you heard about it? Congo red. On Congo red, the pink color amyloid convert into apple green birefringence. Have anyone told this in general pathology while teaching amyloid? I have taken amyloid lecture multiple times. If you have watched my recording or attended my lecture of amyloid, you may be knowing this. So, if I see, listen, this is the pink color amyloid, right? If I see the same on Congo red stain, so in a polarized light, you can see wherever it is pink, it is get converted to green. What I mean, the pink color get converted to green. Can you see? Apple green. So that is the amyloid. For the confirmation, What is the problem ना? It is a pink color in the background. Now pink color तो बहुत चीज़ों का होता है. You will see मैम हमें तो स्लाइड में हर चीज़ पिंक दिखती है, मुझे स्टूडेंट्स आके बोलते हैं तो ये पिंक मैडम अमाइलॉइड है कि ये पिंक हाईलाइन है कि ये पिंक कुछ और है, मुझे कंफर्म कैसे होगा? मुझे लग तो रहा है कि ये अमाइलॉइड है, लेकिन कंफर्म करने का कोई तरीका है क्या कि बैकग्राउंड पिंक इज अमाइलॉइड ओनली? तो मैं बोलूँगी कॉन्गो रेड स्टेन करके पोलराइज लाइट में देख लो, अगर जहां जहां पिंक था वो ग्रीन में कन्वर्ट हो गया तो कंफर्म इट इज अमाइलॉइड. So for confirmation, you do Congo red. You do Congo red. Give me a thumbs up. Come on, give me a thumbs up. Yes, yes. So that is a thing. And here, calcification can also be seen here. Can you see here? I can see the calcification, the blue color here, but blue color here. I have seen calcification in papillary carcinoma also. But there the calcification was in rings, concentric rings, that is known as Psammoma bodies. Here calcification is not in rings. Here I will get simple calcification but no Psammoma bodies, mind my words. Calcification papillary में भी है, medullary में भी है, लेकिन papillary में वो concentric rings में है, spherules में है, जिसे Psammoma bodies कहते हैं. यहाँ पे calcification simple calcification है, डॉट 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 डॉट. यहाँ पे rings नहीं बना रहा वो, तो मैं इससे Psammoma bodies नहीं कहूँगी, मैं सिर्फ calcification कहूँगी. Everyone give me a thumbs up. That's all about the third type amyloid tumor. Can you help me in drawing the diagram? Can anyone? Amyloid की what is the specialty? Amyloid, you want me to write the points or you want me to draw the diagram? I can do both, whatever you say. Shall I write the points? Tell me the pattern. First tell me the pattern, then describe the tumor cell. Can any one of you describe individual tumor cell? Then tell me the characteristic feature of each of them, of this tumor. So the pattern, yes, what is the pattern? What is the pattern? What is the pattern here? The pattern here is nesting. The nest, small nests are there, which are separated by fibrovascular septa. Tumor cell are uniform. All the tumor cells are uniform. Unique feature is the background amyloid. The background stroma have pink color amyloid, which can convert to apple green color on Congo red. So these all are the important points regarding the amyloid histology. Give me a thumbs up. Everyone give me a thumbs up. Right. Can I go ahead? Right. Prognosis is not very good. It's almost 60-70%. It's not very bad also, but 60-70%. So we are done with the third type also, the medullary carcinoma. Let me finish the last also, the anaplastic, then we will do the comparison of all four. Right. The last one is the anaplastic carcinoma. The anaplastic, it's very rare. It's less than 5%, not 5, less than 5. It is the most malignant, most worst prognosis, most malignant of all four. All four में से most malignant is the last one, the anaplastic one. It is less than, but incidence wise it is very rare. It's very rare, but it's most malignant, most dangerous. It is having worse prognosis. It occurs in old age. The age is important. It occurs in old age, 7 to 8 decade. You have to concentrate on the age also. See, papillary occurs in all age, follicular and medullary occurs in middle age. This is all age, this is middle age, this is middle age, this is old age. So learn the age. Gender I have already taught you, right? So all of them are common in female except medullary, which is equal in male and female. So incidence we have seen, age we have seen, male is to female, gender we have seen, right? So we have seen that also. I already told you it is 1.5 times more common in females as compared to male. So female is to male ratio is 1.5 is to 1. It is the most aggressive tumor and rapidly growing. Within few days, it will be like this size. You got my point? So very aggressively going. If you see it is hardly 1 centimeter right now, in the next few days, it will be growing, increasing in size. So doubling time is very less, right? It is the most aggressive. Around the thyroid, what all structures are present? It will invade in the soft tissue, in the muscle, in the trachea, in the esophagus, cause rapid destruction. Can you see here? This is the tumor. It is the anaplastic carcinoma here. It is involving everything around it. It is so, no, in the neck we have trachea also, we have esophagus also, we have muscles also. So all the structures it is invading and involving everything in the neck. Most difficult to treat and prognosis is very worse, very worse. Most of the time the patient dies within few days. Now patient, if the trachea is involved, cannot breathe. Patient have dyspnea, right? If esophagus is involved, patient cannot eat. Patient have dysphagia. If larynx is involved, patient cannot talk. Patient have hoarseness of voice. So these are the complications when other structures are involved. And it is very rapidly involving the other structures, growing everywhere in the neck. In the neck, all the structures are involved. Trachea involved, esophagus involved, larynx involved. If trachea is involved, dyspnea se patient mar jayega, right? Esophagus involved, patient can't eat. Patient have trouble in eating, dysphagia, obstruction in the esophagus. If larynx is involved, the vocal cords are gone. Patient cannot talk, right? Hoarseness of the voice can occur. Give me a thumbs up if you are getting it. The most aggressive one, the most aggressive, right? Grossly nothing important as usual. Large areas of hemorrhage and necrosis milega. That's it, right? Histologically, there is no fixed pattern. I cannot show you one diagram showing the histological pattern. It is very poorly differentiated, right? And it can have three types of morphology: small cells, spindle cells, giant cell. So sometimes you will get small cells, only small cells. You know what are small cells? Small cells are like lymphocytes. The size is small, scanty cytoplasm, dark blue nucleus, right? These are spindle cells. What do you mean by spindle cells? Spindle cells are spindle shaped. Can you see the shape of the cell is like a spindle? So sometimes they are small, sometimes they are spindle, and sometimes they are giant. The giant cells. Giant cells having multiple nucleus in one cell. If you see here, multiple nucleus. So don't learn basically, don't learn the three patterns, don't learn the diagram. This will not come in second Prof university exam to draw the diagram because there is no hallmark in that. So it is having multiple variants, right? Small cell variant, spindle cell variant, giant cell variant. There is no fixed pattern. Anything can occur. The mixture can also occur, right? So there is no fixed pattern, I must tell you. There is no fixed pattern. That's it. That's it. So everyone give me a thumbs up. Everyone give me a thumbs up. I want you to tell me. Now please, everyone will participate. Everyone will participate here. I request all of you. What I am asking now, just answer that question. So I taught you 4 tumors in the thyroid: the papillary one, the first one; the follicular one, the second one; medullary, the third one; and anaplastic, the fourth and the last. Anaplastic, right? Now in the 4 tumors, you tell me first of all the incidence of each of them. Incidence, the percentage of incidence, which is most common, which is least common. Then you tell me the age in which they occur more commonly. Then you tell me the female is to male ratio in each of them, right? Then you tell me the cell of origin in the thyroid in each of them, the cell of origin in each of them. Then gross सिर्फ papillary का important है, बाकी का तो important नहीं है. You tell me the gross. In the microscopy of each of them, you tell me three things. Number 1, you tell me the pattern in each of them. Number 2, you tell me the tumor cells, peculiarity in each of them. And number 3, you tell me the hallmark feature of each of them. If you can fill this with me, it is a master table. It is the master stroke. Just revise this before your any exam. Whatever exam you are targeting doesn't matter, right? It is a complete master table. Can you help me with the incidence? Yes. So I want all of you to participate. Please, everyone. Incidence, you are absolutely right, Talim. It's 70 to 80%. It is the most common, right? Follicular is, what is the follicular percentage? It is 10 to 20%. Second most common. This is 5%. This is less than 5%. So this one is most common. This one is least common. Yes, very good. Can you help me with the age? All of you, age. It occurs in all age. Papillary. Only papillary can occur in all age. The young also, the old also. Follicular occurs in middle age. Medullary also occurs in middle age. Anaplastic occurs in old age. Age will give you a clue in big clinical question. So you will get a big clinical question like this: a 70-year-old female. So it should click you. It can be anaplastic, more chances. आगे पूरा पढ़ने से पहले, because the age is 75. If the age is 30, 40, the chances are like this. Papillary में कुछ भी हो सकता है. A small kid can also have it. There is no particularity in the age. Now tell me female is to male. So only medullary is 1:1. Male and female equal. Rest all the female is more common. Here it's 3:1. Here it's 2.5:1. And here 1.5:1. Everywhere female is more common. But only medullary female is equal to male. That you have to learn. Yes, you have to learn that. Yes. Now you tell me cell of origin. So only medullary, the cell of origin is parafollicular. Rest all are follicular, follicular, follicular. Since medullary is parafollicular, so blood में calcitonin is abundant and that can cause hypocalcemia. That can cause hypocalcemia. Give me a thumbs up. Come on, everyone. Yes, appreciate the efforts. Gross is important only of papillary. The papillary projections can be seen. Rest gross are not important, not for theory, not for MCQs. Coming on microscopy, who will tell me the pattern in each of them? Here the pattern is papillary pattern with fibrovascular core. I have drawn the diagram. Here the pattern is follicular, the circular, the follicles of varying size. Here the pattern is nesting. Here the pattern is nesting, right? Small nest separated by fibrovascular septa. Here pattern is like sheets. So complete filling of the tumor cells, sheets. So learn the pattern. In that pattern, you have to draw the diagrams. Come on, come on. Yes. Exportin, absolutely right. Now tell me about tumor cell. So in tumor cell, here three things are important in papillary. The three things about the nucleus of the tumor cell. Number one, the color of the nucleus here, the only tumor where the nucleus is transparent. So nucleus is known as ground glass appearance. It is like a glass. Also known as optically clear nucleus, right? Also known as orphan Annie Eye nucleus. Say yes. Rest all the tumors, the nucleus is hyperchromatic. By the term hyperchromatic, I mean opaque nucleus. You got my point, right? Second, here nucleus shows grooves. Third, here nucleus shows inclusion bodies. That is about the tumor cells, right? And tell me the hallmark feature also. Lagya do, wo bhi bata do. The hallmark feature here is Psammoma bodies. Psammoma bodies is the calcification in rings. So that is a hallmark of papillary. You got my point? In follicular, the tumor cells I have already described. It's hyperchromatic nucleus, nothing more important here. And the hallmark feature, what is the hallmark feature in follicular? It's capsular and vascular invasion. Very much invasive, capsular and vascular invasion. You got my point? Capsular, and there is one variant. The variant is known as Hurdle cell or oncocytic carcinoma, which is a variant of follicular having more pink, more eosinophilic cytoplasm. Right, coming on the medullary. Medullary mein the hallmark feature is that the cells are uniform. All the cells are uniform. There is no pleomorphism. Rest everywhere pleomorphism is there. The hallmark feature is that the background have pink color amyloid. That is known as amyloid stroma. You cannot forget that. And the to confirm amyloid, do Congo red. I'm sorry. That is gone. I'm sorry. I cannot bring that back. The sheet is gone. Anyways, we have nearly completed that. In anaplastic, there is nothing fixed. The three patterns are there. Small cell, giant cell and spindle cell. That's it. So yeah, this is how you have to make this table. Everyone with me? Give me a thumbs up. Everyone. So you have to learn that. Right. Now, how to diagnose these tumors? Imagine in your clinic, a patient is coming. A patient is coming like this. Sorry, let me draw a patient. The neck should be wide, no? I must tell you the thyroid here. The patient is coming to your clinic having a nodule in the thyroid, right? A nodule can be visible or sometimes it can be seen on the sonography. So this is the thyroid gland and the patient is having a nodule in the thyroid. Now you are having suspicion that this patient can have one of the thyroid tumor, right? It can be any of the four, right? It can be any of the four. She is a female. Right, she is a female and it can be any of the four, right? Now, how to diagnose it? What is the best way to diagnose? The best way to diagnose is do FNAC. Don't do biopsy. Thyroid is a very vascular gland. You know, if you do biopsy, bleeding ke chances zyada hote hain. Do FNAC. It is less invasive, it is less costly, cheaper, and results can be given very fast. So do FNAC. You know what is FNAC? Fine needle aspiration cytology. So take a needle, just insert the needle inside this lesion. If you can palpate it, just insert the needle with an empty syringe behind. So insert the needle like this in the neck and do to and fro motion like this, right? So that the cells will be dislodged. The cells inside that will be dislodged and then take the plunger of the syringe backwards. So whatever the cells dislodged here, they will come and filled in the syringe. So that syringe, whatever material 0.5 ml, 1 ml you are taking out, that contains the dislodged cell, and take it on a slide, make a smear, stain it and see it. This is known as FNAC, right? So like this you can do the FNAC. By FNAC, out of the 4 tumors, the 3 can be diagnosed. Follicular cannot be diagnosed on FNAC. Please learn it. For follicular, you have to do the biopsy. Yes, I'm coming on that point. For follicular, you have to do biopsy. The rest 3 can be diagnosed on FNAC, right? The rest 3 can be diagnosed on FNAC. If you are doing the FNAC now, so there are 4 types of tumors: papillary, follicular, medullary, anaplastic. Don't change the sequence, never. So if you are doing FNAC, here you will see the cells with orphan eye nuclei, you will see the grooves, you will see the inclusion bodies, you will see the ground glass appearance nucleus. That will be very peculiar cell, jo aur kahin nahi milenge. You will get the point that it is a papillary carcinoma. In medullary, all the cells which are coming out in FNAC, they will be of uniform size. Number 1, and you will see pink color material, that is amyloid, will also come in the syringe, right, on the slide. So that will give the confirmation. If you do the congruent, the confirmation will be done, right? In anaplastic, the cells will be highly pleomorphic. Some will be small cell, some will be giant cell, some will be spindle cell. So that is also diagnostic. In follicular, there is no diagnostic feature. Like the follicular cells will come here in the follicles only, but you cannot, based on FNAC, you cannot differentiate. There are two types of follicular tumors actually, one benign, one malignant. Listen, listen. Follicular दो चीजें होती हैं. Follicular adenoma होता है जो कि benign है. Adenoma is benign. And follicular carcinoma होता है जो कि malignant है. Carcinoma. You got my point? In my neoplasia, I always teach you to see the suffix. Oma is benign. It is a benign tumor of the thyroid. Today I don't taught you the benign tumors. I taught you only malignant tumors. So I taught you follicular carcinoma. I didn't taught you follicular adenoma, but it happens. होता है ये भी. मेरे आज का topic था the malignant tumors of the thyroid. I taught you all the 4 malignant tumors. I didn't taught you benign, na? Right? But follicular adenoma is one of the benign tumor. You must know it. Now, how to differentiate both of them? If you see the slide of both of them, the tumor cells are arranged in follicular pattern in both of them. In both of them, the circles, follicles. The only way of differentiating the two is the invasion. Listen, the only way of differentiating the two is the invasion. The invasion in the capsule and the invasion in the blood vessel. Capsular and vascular invasion. It is absent in benign and it is present in malignant. If the capsular vascular invasion is absent, it's follicular adenoma. And if capsular vascular invasion is present, it's carcinoma. Please understand this point. Listen, understanding is important, right? रट तो सकते हो, लेकिन समझो इस point को. मैं ये चाहती हूँ. Let me draw 2 slides. There is a patient, 30-year female in my clinic, having a nodule in the thyroid. I'm having a suspicion some of the tumor may be benign, maybe malignant, I don't know, right? So if I do FNAC of this, so in the FNAC, it's like this. Both the tumors are showing the follicle arrangement. On the follicle arrangement, the cells are present, right? Now, in the FNAC, I cannot say whether vascular or capsular invasion is present or not. For invasion, to see the invasion, you have to do the biopsy. FNAC पे cells दिखते हैं, right? Invasion नहीं दिखता है, right? Invasion देखना है तो biopsy करो, right? So you cannot say, ma'am, it is adenoma or it is carcinoma. I can say one thing for sure, it is follicular. It is follicular because the arrangement of the cells is like follicle. But follicular adenoma है कि carcinoma है, वो कैसे पता चलेगा? उसके लिए biopsy पे देखना पड़ेगा invasion. So if blood vessel and capsules are invaded, it's carcinoma. If they are not invaded, it's adenoma. Give me a thumbs up. So FNAC is of no use for follicular. For rest all, you can do the FNAC. So FNAC is the best investigation of all thyroid tumors except follicular. Because on FNAC, you cannot differentiate follicular carcinoma from follicular adenoma. For differentiating, you have to do the biopsy. In the biopsy, you have to see capsular and vascular invasion. Give me a thumbs up, everyone. We are done with the 4 types of tumors. Can you help me with the revision? Yes. See the papillary carcinoma. See the arrangement is papillae on a fibrovascular stalk. See the tumor have ground glass appearance, right? Orphan Annie nuclei. See the grooves, see the inclusion bodies, see the Psammoma bodies. So all the things are there. See the follicular, right? See the medullary, see the amyloid. Don't miss the amyloid stroma, right? And see the anaplastic, the various patterns, right? So give me a thumbs up, everyone. We are done. Everyone give me a thumbs up. Everyone give me a thumbs up. Yes? Can I move ahead? Say yes. So we will solve some MCQs now and you will answer me. You will answer me. Yes, Ayush, absolutely right. Adenoma is well circumscribed and adenocarcinoma is poorly circumscribed. But circumcision we cannot see unless until we take the complete thyroid gland out. We are taking the complete tumor out in thyroidectomy, near total or partial thyroidectomy. Then we can see the boundaries of the tumor. Inside the patient, looking at the boundaries of the tumor is difficult. I want to make the diagnosis in the patient before I operate the patient, right? So being a surgeon, first I want to make the diagnosis. It's an adenoma or carcinoma. If it's adenoma, the surgery will be different. If it's carcinoma, the surgery will be different. And after, if it is carcinoma, after surgery, I will offer chemotherapy, radiotherapy also to the patient. If it is adenoma, I will not offer that. So diagnosis within the patient, we have to make. Yes, after taking out, we can see the boundaries. You are right. It's very, very sufficient for MCI exam talim. It is even more than that. इसके आगे एक भी question नहीं आएगा. Whatever exam you are targeting, all the things are covered here. That's it. Now we will solve all the MCQs, the past 5-year papers of FMG exam, of NEET PG exam and of INICT exam, right? We will see. So listen, the first question is in front of you. Can you give the answer? The feature that differentiate follicular carcinoma and follicular adenoma. Which feature differentiate the two? Just now I taught you. The four options are in front of you. Is it nuclear pleomorphism? Is it Hurdle cell? Is it capsular invasion? Or is it absence of colloid? What does differentiate a follicular adenoma or carcinoma? That is benign versus malignant tumor. The follicular carcinoma or adenoma. Gajanan and Ayush, Pinky, you are absolutely right. What others are doing? Are you sleeping? Yes, Osama. Yes, at least participate now. It's B or C. Osama, Talim. Is it B or C? Just now I told you it's only invasion, the vascular and capsular invasion. Don't say Hurdle cell. Hurdle cell bhi dono mein hote hain. Don't get confused, Osama. Don't get confused. Hurdle cell can occur in both. Adenoma also, carcinoma also. It is a variant. It is a variant. You cannot say it is peculiar for carcinoma only. Whatever follicular thing is there, it is present. It is only invasion. It is only invasion. So correct answer is C, not B. The correct answer is C. The invasion differentiate adenoma and carcinoma. Which invasion? Vascular invasion and capsular invasion. So it is the only criteria to differentiate follicular adenoma and carcinoma. If invasion is absent, it is adenoma. If invasion is present, it's carcinoma. That's it. Everyone give me a thumbs up. Yes, you all are right. Can you tell me the next question? I guess everyone will be right. The Orphan Annie Eye nuclei is a characteristic feature of which carcinoma? Is it papillary carcinoma of thyroid? It is pituitary carcinoma, paraganglionoma or meningioma? I guess everyone is right. Yes, Gajanan, Gaurav, Pinky, Talim, Osama, very good, great. So of course it is papillary carcinoma. अभी पढ़ा है तो सबको याद है ना ताज़ा ताज़ा. लेकिन जब पूरे 19 सब्जेक्ट पढ़ के एग्जाम में बैठने जाते हो ना तो इतने सिंपल क्वेश्चन भी तुम लोग गलत करके आते हो. I don't know why. और बाहर आके बोलते हो मैम सिली मिस्टेक हो गई. Don't do such silly mistakes. Whatever you are reading now, fit in your permanent memory. Just fit it, right? So that is your orphan eye nuclei. Great. So the correct answer is A, right? Orphan eye nuclei seen in papillary carcinoma. Papillary carcinoma of thyroid. ज़्यादा अच्छा क्वेश्चन होता when you get all the four option of thyroid carcinomas only. चारों ऑप्शन ऐसे होते हैं papillary, medullary, follicular and anaplastic. तो ज़्यादा अच्छा क्वेश्चन होता है and you will get confused. But the correct answer is still papillary carcinoma. Yes. So going to the next question. Can you tell me Hurdle cell carcinoma is a variant of which carcinoma? Is it a variant of medullary carcinoma? Is it a variant of papillary carcinoma? Is it a variant of follicular one? Or is it a variant of anaplastic one? What you will say? Yes. So Kumar, Bubbly, Gajanan, Talim, yes, Pinky, absolutely right. So what is the correct answer? Of course, Hurdle cell carcinoma is a variant of follicular carcinoma. Great. So in Hurdle cell, the only difference, the cells are bigger, abundant cytoplasm, granular cytoplasm and more pink cytoplasm, more eosinophilic cytoplasm. Yes, yes. Very good. You all are right. The correct answer is C. Absolutely right. I want everyone to participate, please. This is the next question. FNAC is of least diagnostic value in which carcinoma? Least. So FNAC is of no use in which carcinoma? So is it anaplastic, papillary, follicular or thyroiditis, which cannot be diagnosed on FNAC? Which cannot be, for which you have to do the biopsy, which cannot be diagnosed? Yes, you all are right. Just now I told you it's follicular. Because in follicular, whether it is adenoma or carcinoma, you cannot differentiate on FNAC. That's why FNAC is of no use for follicular. For rest all, FNAC is the best investigation. Yes, the correct answer is C. Just now I taught you. Very good, very good. This is the next question. Which is most common thyroid tumor? Incidence wise, which is most common? Papillary, follicular, medullary or anaplastic? Which is most common? I told you the percentage of each of them. Yes, very good Kumar, Gajanan, Gaurav, Talim. Yes. So it's 70 to 80% is papillary. So correct answer is A. If I change the question and say least common, what is your answer right now? In the same four options, what is your answer now? If I ask least common instead of most common, what is your answer now? Yes, Gajanan, very good. Yes, yes Kumar, then your answer will become D, right? So it depends what is the question, right? If I'm saying second most common, what is your answer now? Not most common, second most common. Second most common, your answer will become follicular. So you should know the sequence. Papillary, followed by follicular, followed by medullary, followed by anaplastic, PFMA. The sequence is this. So whatever is the question coming, you can solve that. Give me a thumbs up, everyone. Can we go ahead? Yes. Okay. I told you this thing. Lymphatic spread is most common in which thyroid cancer? I told you. Lymphatic spread सब में होता है, लेकिन most common किस में होता है? Papillary or medullary or follicular or lymphoma? Yes. So Gajanan, Bubbly, you are saying B, medullary. What about others? Lymphatic spread सबसे common किस में होता है? ये okay, papillary. I have given the answer papillary. I have told you medullary. No, it should be medullary. It should be B. But let me confirm. I will get back this question to you again. Why I have written this discrepancies there? But give me some time. I will get back this question to you. Let me confirm it. I guess the answer should be medullary, but I will confirm it to you. Anyways, coming to the next question. Okay, medullary carcinoma is associated with increase in what? In the blood, you will find increase in what? Is it calcitonin which will be increased in blood, T3, T4 or thyroglobulin? In medullary carcinoma of thyroid, what will be increased in blood? The easy question. So medullary carcinoma arises from parafollicular cells. You cannot forget that. And parafollicular cells secrete calcitonin, and that's why you all are right. Of course, blood mein calcitonin badega. So calcitonin will be abundant in blood. So these are the clues in the question, right? Which of the following gene defect is associated with medullary? Tell me the gene which is mutated in medullary. Is it RET oncogene? Is it FAP? Is it retinoblastoma or is it BRCA? Which gene is mutated? Of course, you all are right. It's RET gene. It's RET gene. You have to learn the mutation also. Mann syndrome is associated with which tumor? Which thyroid tumor? Papillary, medullary, follicular or anaplastic? In चारों में से man का association किससे है? Of course, it's medullary. Medullary is associated with MAN2A and MAN2B, not with MAN1. MAN2A and MAN2B mein association, it is familial. So only medullary is familial. So you all are right. Very good. Very good. Most common thyroid cancer which occurs post radiation. Radiation se association. Radiation is a risk factor for which of them? For which among the following the radiation is a risk factor? Papillary, medullary, follicular or none? What you will say? Yes, fast. Come on. The questions are very easy. Come on. Yes, you all are right. So for papillary carcinoma, I told you two risk factors, radiation and thyroglossal cyst. Yes, no pinky, it's not follicular. The correct answer is A, right? So whatever mistakes you want to do it here now. Don't do it in exams, right? So papillary carcinoma ka sabse zyada association hai radiation. I told you. So please learn it. Correct answer is A. So I would like to stop here. Apart from which, I'm having a set of clinical questions. You know, these were the one-liner question. I'm having a set of clinical questions on thyroid tumors. I'm having a set of image-based questions on thyroid tumors. So if you wish, I can share the file with you. You can try solving. So take the clues in the clinical question. IBQs are very simple. You have to see. It will be spotter-like. You have understood the image of all four now. If I give you any image and ask for particular labeling, you can do that. If I give you any particular image and ask you what is the image of which of the thyroid tumor, you can easily identify it. You have to see on the features. You have to see the arrangement. You have to see the tumor cell, right? So that is the thing. Image based question बहुत सारे बन सकते हैं इस पे, right? So we will try to solve these questions in the next session if you wish, right? So okay, I will share it on the WhatsApp, right? So don't forget to ask your doubts on this number. This is my contact number. It's 9833032948. It's my contact number. You can text your doubt either on WhatsApp or on Telegram on this number. If you have doubt in patho, pharma, micro, PSM or medicine, don't forget to ask your doubt, right? If you find any particular topic difficult, please text me that topic also. I got numerous requests throughout the country, even out of the country. Many students message me. Daily I get more than 100-200 messages. So there is a little bit delay in replying all of them. But whenever I will get time in the next 1-2 days, I will definitely get back to you. Don't worry. It's not unattended. Don't think ma'am is not replying. Don't think like that. It is attended, but it will take time. Maybe in the next 1-2 days, I will definitely get back to you. And I am making the list. Whatever request I am getting from all of you now. So on the priority basis, if many students are demanding the same topic, I am launching it before. And if only a few students are demanding one topic, it is there in the list, but later on, right? So I daily take live lecture 9 a.m. in the morning. The topics are not decided by me. The topics are decided by you people only. So I get requests from the student and I take that topic 9 a.m. in the morning live free classes. So whatever topic you find difficult, kindly let me know. Thank you very much, right? So I would like to end here. Thank you for being with me daily. You are coming here, giving your precious time to me. I'm really grateful to you and I'm really thankful to you. If you like the lecture, don't forget to click on the like button. Please share the link of this class to all your friends, colleagues. Please share the links on your batch groups, right? These are the free session. Everyone can get benefit out of it, right? All the medicos you can share. If you have not subscribed my YouTube channel and not pressing the bell icon for getting notification, you are doing a big mistake. So daily you will get the notification when I will go live. So I will see you all tomorrow 9 a.m. in the morning, again with a new topic on huge demand of the students, right? Which is important for your exams, of course. And the last thing, in the comment section, there is one link given, the pinned link. You can see the pinned message. It is a link given. You have to click on that link. In that link, all the social media links of me are given. I'm available on Instagram, on WhatsApp group. You can add on the WhatsApp group, on the Telegram. Please connect me everywhere so I can give you as much as study related, exam related material to all of you on all the platforms. So I request you to click on the link and join me on all platforms. Thank you very much. See you. Bye-bye. Study hard. All the best. And I'm ending this session.